Good evening, everyone. Welcome to this evening's Medicine for members. We are live on Zoom and Facebook. I'll now hand over to Emma Rose, Safety and Quality Midwife, and our host for this evening. Thank you.
Good evening. Thank you, Namu. So first of all, a very warm welcome to our members for joining, and a welcome to other members of the public, especially those of you who are joining for the first time. Anyone who's not yet a member, feel free to sign up via our website, which is www.cuh.nhs.uk, and you can be invited along to future events. So today's topic is obstetrics and gynaecology, and it's about improving pregnancy outcomes. And I've had the privilege of working with our speaker today for the last 3 years, so it's an absolute pleasure to introduce you this evening, Dr. Sue Chong, consultant in maternal and fetal medicine at the Rosie Hospital. Sue is also our obstetric lead for investigating stillbirths and neonatal deaths at the Rosie Hospital. She is passionate about improving outcomes for mothers and babies, and we see this in all aspects of her work at the Rosie. She's a dynamic and forward-thinking member of our multidisciplinary team and continuously goes above and beyond to make effective evidence-based service improvements. And above all else, through her sensitive patient-centred care, Sue makes a genuine positive impact on the experience of the women and families in her care. So a very warm welcome this evening to Sue Chong.
Thanks very much, Emma. I feel quite embarrassed by these very generous comments that you've just given me. I want to thank Namu for giving me this opportunity to talk to our Medicine for Members team. I'm going to start sharing my screen, Namu, if that's all right.
Sure, Sue.
And sorry, just.
Oh.
Okay, and is it moving from one slide to the other? Okay,
yeah.
Yes, so I think what I really wanted to do today was to talk in broad terms about what we are doing at the Rosie to improve pregnancy outcomes. And pregnancy outcome is quite a broad concept in a way. My main role, and I work with a team of people, is to investigate stillbirths and neonatal deaths. But across the Rosie, we are a big team of people who are trying to improve overall pregnancy outcomes. I'll start first of all by telling you about the national initiative to reduce stillbirth and neonatal death. And this was a government initiative that was announced some years ago to halve the risk of halve the incidence of stillbirths and neonatal deaths by 2025. So it's not a small thing that we can do in isolation, and we really need everybody's involvement in this. Just to give you some idea of where we are at the Rosie, this is nationally collected data, and this is because we have we feed back into a national database that's collected by Oxford. It gives us more or less real-time data in regards to where we are in terms of our stillbirth risks and rates. So if you look here, first of all, you'll see that our crude stillbirth rate is 2.28 per thousand. And once you adjust that for our complexity and the population that we have, taking into consideration that we have a level 3 neonatal unit, that comes up to about 3.5 per thousand. That's kind of how to read the data if you're interested in that kind of thing. And because we are Cambridge, we like to compare ourselves to the other place. And you'll see that in the other place, the crude rates are in orange, so a little bit higher than where we are. But when you stabilize it and adjust it for the complexity of that population, you'll find that our rates are very similar. So 3.65 in Oxford versus 3.5 for us. So there's very little difference between the two centers. And these comparisons are absolutely important because you can think that you're doing well as a unit based on what you're seeing for your unit, but you don't know how the other units are doing. And so this allows us to benchmark between each other to a certain extent. I'm just going to move on. What we want to do is try and improve outcome. So you have to balance the risks of being born early versus the risk of stillbirth. This is a picture that I got from the Grace Hayes Research Fund, and then this was from when I used to work in University Hospital Coventry in Warwickshire. And Grace was born very, very early and sadly passed away. But we are making big strides in trying to both improve pregnancy outcome by preventing premature births, but also trying to reduce the stillbirth risk by timing the delivery correctly. In terms of where we are with the level of complexity for our unit, we get about 10% of the population of Cambridgeshire transferring into the Rosie. So this is data that we collected over a 9-month period that showed that maternal, medical and fetal reasons are one of the commonest reasons for transfer. So that's 25% of women who would just be transferred in the middle of pregnancy when they started off their care somewhere else because of medical reasons for mom and because of fetal reasons. These fetal reasons are different to the women who present with premature rupture of membranes, who have transferred because of going into preterm labor early. These are purely because of a fetal concern or because the maternal health has deteriorated such that we need to look after them here. It's not an insignificant population. It works out to about 10 per month, I think, but it comprises 25% in total. So that is good for us because we're delivering good care, but also it adds to the level of complexity of care where we're thinking about caseload mix and service provision and trying to balance the care that the midwives are able to give in terms of complexity. And also it has an impact on our neonatal unit. We are very lucky because we have surgical services at Addenbrooke's. So we're one of the very rare units in the whole country where if a baby needs to have surgery, they do not have to be transferred to another hospital if we have those pediatric services. So some of the things that babies that we deliver sometimes have gut differences where the bowels are found on the outside because the belly button hasn't closed off properly. So that's called a gastroschisis or an omphalocele. And because we have such excellent pediatric services, those women tend to come to us for delivery, and they can come from as far as Ipswich, or they can come from as close by as West Suffolk Hospital. Some of the other reasons that we see these transfers for fetal reasons are because of growth restriction. There's been a lot of information in the media recently, especially in the context of what's happening in the West Midlands. And you can read the full report that's available from the government, but I wanted to focus on what we're doing well so that we can share the learning that's happened, and you can learn from adverse events, but you can also learn from what went really well. And this patient has allowed me to talk about her story, but didn't want to be on the screen because she was a bit shy. So this was a singleton pregnancy that booked at West Suffolk Hospital. The lady was risk assessed according to their triaging system and was started on aspirin. We have good evidence now that low dose aspirin can reduce the risk of preterm preeclampsia. So she was given appropriate treatment to try and prevent this. But unfortunately, it doesn't work for all women. And so she was unfortunately diagnosed with preeclampsia at 25 weeks. She had her scans at West Suffolk Hospital and they informed us of the change in her complexity. So she developed a pregnancy complication which can be potentially life-threatening, and it's characterized by having high blood pressure and also protein in the urine. The word eclampsia means literally a bolt out of the blue, and it manifests in the form of a seizure. The word pre means that phase before that, and we don't have any good tests actually that can tell us when exactly a complication like eclampsia can happen. So all that we can do during the pregnancy is to look after the woman, to do blood tests, to monitor for signs of symptoms of disease progression. Because this baby was, or the woman was diagnosed with preeclampsia very early, they gave us a phone call because they were concerned that she needed delivery, and the West Suffolk Hospital are unable to take babies that early on. And so care was transferred to us. We looked after her for about 4 days. We gave her what we would normally do to optimize her health in terms of preparation for delivery, and that's in the form of steroids to help with the baby's lungs. We also gave her a special salt called magnesium through an intravenous drip to reduce the risk of preeclampsia in the form of a seizure, but also to improve neonatal outcome, because we have good evidence as well that magnesium sulfate before delivery can reduce the risk of cerebral palsy. And during the period of her monitoring, she underwent what's called a placental abruption, where the placenta separated from the surface of the uterus, and she delivered by emergency cesarean section. So this can all sound like it didn't go very well to people listening, but it's really important that she received to know that she received the care that she needed at the right time. So she had aspirin. They gave us a phone call, so they communicated to us about the change in her level of complexity, and then we facilitated the transfer after discussion with our neonatal colleagues. I wanted to show you a picture of this machine because we were very lucky that we got funding from ACT, the Addenbrooke's Charitable Trust, because this has allowed us to help early babies get the best care. And that allows us to get as close as we can to the mum delivering, and allows the baby that's born preterm to have what's called delayed cord clamping. And it seems like a very simple thing, but babies don't need very much. They just need feeding, watering, keeping warm, but this very crucial process of delayed cord clamping can help the baby's natural transition to being born, compared to if the cord was clamped immediately. I think this has been known for hundreds of years, but this device has only been developed in the last maybe 5 years. That's allowed us to really get close, as close as possible to mum, to help with that neonatal transition. So we're very grateful to ACT for that. So this is just an example of how things can go really, really well. And it's in very simple terms, just simple communication between hospitals, simple communication with the woman, because it allowed her to be a very critical part of that care pathway. She was involved in all the decision making. She was fully aware and didn't feel scared or shocked by what had happened. And baby, I think, is currently about 31 weeks and is doing quite well on the neonatal unit. So from our point of view, from a holistic care point of view, I think we did really well. It's important to remember that we can still achieve good care, even in the face of complexity. I took this picture because this is the lovely Tracy's arm. She's a midwife who works in close observation. She didn't want me to take a picture of her, but I love this because I think that I am so lucky to work with Tracy, and I hope that I embody that spirit as well in the culture, and certainly I hope people feel that I'm nice to work with. I wanted to give a shout out to Liz Hopkins and Janice Scott, who are part of the team members who do the PMRT for me, or with me, sorry, not for me. I say for me because Janice Scott does a lot of the administration to make sure that we get all the information that we need from the DGHs that take part. But I also have the lovely Kathy Bevins, and I've stolen this picture from her Twitter, I think, and Shazia Hoodboy, who is the neonatal lead consultant for PMRT. I have a great team because we all are actually really passionate about making sure that when a woman has had the very sad loss of a stillbirth or neonatal death, we put real learning into the care that she's encountered, just to make sure that we can improve every single aspect where it has been deficient. So I'm very lucky to work with them. Tracy looked after this lady who came from West Suffolk, and so I'm sure she wouldn't mind if I include her arm in this picture. And then we're also very lucky at the Rosie because we have really excellent research leadership. So this is Professor Gordon Smith, and his work on the POP study that took place about 5 years ago now has led to important changes for the identification of growth restriction. And POPs 2 is now underway and is in full swing post-COVID. And the idea of POPs 2 is to allow us to identify a test that can help potentially distinguish between severe preeclampsia better. I also wanted to give a shout out to Charlotte Patient because we talk a lot about preventing stillbirth and improving neonatal outcomes. But sometimes we are unable to do that, and women still undergo and experience stillbirth. Charlotte Patient is one of our consultant obstetricians. She runs the Rainbow Clinic with a team of specialist midwives, and they look after women who have undergone stillbirth, and they're very passionate about doing this. And Charlotte's also leading on a big work stream within Cambridgeshire as part of our maternal medicine network, and she's the lead on that, because at the heart of it is the woman. And yes, we are looking after women and their babies, but we still have to look after women's health. And I think we're very lucky in Addenbrooke specifically, because we have a lot of physicians that have an interest in this, and they don't mind being asked questions. And in that process of asking questions, we feed back to our team and learn together as a team. And then it takes a village to look after pregnant women, and this is the rest of my team at the Rosie of consultant obstetricians. This is Michelle Kemp. She and Alison Wilson look after women who have mental health conditions, and also Michelle does hematology. That's the rest of them that you can see there. Kasha looks after women with twins. Jenny and Jerry are setting up a placenta creta service together. And we also have lovely input from Joanne and Shala Bakhtiari, the consultant midwives. Some women with complex pregnancies will sadly have to make the decision to end their pregnancy, and we have an excellent service to kind of support them through that process. We also have, I consider Rachel Barrett, who is a combined consultant obstetrician and gynecologist, my main gynae go-to person, and she's my link to the rest of the gynae team. We, at the drop of a hat, will often say to our anaesthetists, I need to do an emergency cesarean section now, and we need a neonatal cot now, and we absolutely cannot look after women and do the best of our ability without our anaesthetists and our NICU team. So I also wanted to thank them. I'm happy to take any questions. I think that's the last slide. Oh yeah, one more thing. My goals. So we are now in 2022, so we've got 3 years to get to 2025. We have in place smoking cessation midwives, but what we really need, and what the common themes are coming up from this, is help with smoking cessation. NICE have actually introduced incentivized smoking cessation as part of their guideline for pregnant women. We know that smoking is associated with growth restriction. We know that smoking is associated with cot death. We know that smoking is associated with complications in later life. And if you think about where to target the smoking cessation, there's no greater time than to do it at the start of pregnancy, when a woman is most motivated to stop. A neonatal cot per day costs something in the region of £1,300. It will cost £400 to help a woman stop smoking in the duration of a pregnancy. If you treat or help women to stop via incentivized smoking, if you help 1,000 women stop, 117 will actually stop permanently. And if you think about public health initiatives in terms of later life issues, there's a really strong motivation to try and help women stop. Then the second goal is to support our local maternity neonatal service. And that is in the form of, again, providing fetal medicine support, helping them with managing complex pregnancies and fetal growth restrictions. But also the next step will be to undertake external reviews so that we can learn together, and then still focusing on the right baby being born in the right place. And finally, I think there's been a lot of challenges in COVID times in terms of just feeling a little bit worn out by the shortage of staff shortages from what's coming out from the impact of Ockenden. But I think that one of my personal interests is creating psychological safety, and that's not just from the point of view of people being able to talk to me about women and their patients, but also conducting debriefs so that members of staff who've been involved in complex cases where there has been a loss don't feel they're not able to come back to work, because staff retention is going to be an important focus as part of this whole package of improving maternal and perinatal health. Thank you.
Thank you so much, Sue. That was a really fantastic talk. There's a lot to cover in a short time, so you did brilliantly. So I meant to mention before I let Sue start, actually, that we are open to questions and answers. So if you have anything you'd like to put in the Q&A chat box, and that's for Zoom attendees, then please do. And then for Facebook attendees, if you just insert your questions onto the Facebook comment box, they'll be picked up, and then I will relay them into back to Sue. If there's any we can't finish off, then we will get back to those individuals personally afterwards, so that you get answers. So the first one we've had is a question from Millie Skills on Facebook. She just wanted to know if the baby in the case that you mentioned from West Suffolk survived.
Absolutely, yes. I think one of the real advantages and one of the real positive predictors of survival for that case was that baby was a good weight, but also had, and I'm biased, quite possibly the best care she could have ever had, because we had a great neonatal team to support her. Baby, I think, so this was some months ago, I think she's about 30-ish weeks now, 30, 31
Must be about
weeks.
6 weeks or something.
Yeah, so I think about 31 weeks, and we'll probably be heading back to West Suffolk Hospital when they can accommodate. So she's doing very, very well. Thank you for asking.
Lovely, thank you, Sue. And then I have a question asking whether we offer advice or support for promoting physical activity during pregnancy. So a bit more of a general one there.
Yeah, there's been a recent update from the obstetric medicine group from Oxford, and there's very clear guidelines that light exercise and 30 minutes exercise is absolutely fine. It's good for mental health. It's good to get out in the fresh air. I would say there may be certain precautions that you need to take. So, for example, if you're going for a run, don't go for a run somewhere where you don't have phone reception, just in case you fall and hurt yourself and it's hard to get help from that point of view. If you want, I can find that information and then send it to Namu, and Namu can put it out somewhere on Facebook. But yes, exercise is definitely a big positive.
And then we have a question from Christopher Van Essen asking impact of Ockenden, what's that? Which I think is I'll let you take that one.
So it's in the media, and I don't think anybody has been able to escape it. So the Donna Ockenden is a very experienced midwife who undertook a series of reviews, and she had a big team behind her to investigate all the stillbirths and neonatal deaths that happen in one specific hospital in the West Midlands called Shrewsbury. It's a very big document, and there's a lot of aspects of care that we can definitely learn from. What you will see in the media is that there is a focus on mode of delivery, but actually the care encompasses the whole of the pregnancy, and there are many, many aspects of care that we can definitely learn from. It makes for very difficult reading, because as an obstetrician, as somebody who works in maternity, you really feel for those families. You really feel for the families that have lost their babies either in the antenatal period or in the postnatal period. And I definitely personally don't ever want it to happen here. And so for me, that's why this concept of psychological safety is really important, because I don't want to be that consultant who people can't talk to. And I hope that I kind of pass off that vibe to my junior colleagues. There may be moments when in an emergency situation, I may be a bit short, and I apologize for that in advance.
I think it's so important, that open culture. It's something that is very much nurtured at the Rosie Ann Brooks. And then we have a question from Jenny Porter. What is the difference between a stillborn and a neonatal death?
So a stillborn baby is a baby that has sadly passed away whilst the mother is still pregnant. And a neonatal death can be defined into early and late phases. An early neonatal death, I believe, happens after the baby is born and within the first 24 hours of life. And then I think the late neonatal deaths happen up to 28 days. So some of our babies are born extremely early, but unfortunately don't make it. So they may pass away at some point in that neonatal period, and that's really, really unfortunate for the families. One of the things that we are really interested to do, and that's part of the learning from doing the perinatal mortality reviews, is that some hospitals didn't have an established preterm birth service. Some hospitals also were not aware of risk factors for preterm birth. So in that review process, we've been able to feed back to them to say, these are the risk factors. You could consider introducing it into your service. Otherwise, we'd be more than happy to see them here, because the babies were transferred here, so we have that history. But I think nearly all of them now have a consultant who has an interest in preterm birth. We have our own. So we have Ms. Hoveda and Asma Ishaq, who both run the preterm labor service. And are both very, very interested in trying to prevent and improve care from that point of view.
Thank you, Sue. And at the moment, I think we've completed all questions. I don't know if anyone wants me to give it a little bit longer. Otherwise, I'll hand back to Namu. Nothing else coming up at the moment, so hopefully that means you were very comprehensive. I'm sure if anyone has any further questions, if they contact Namu, then she can pass them on to us as well. Okay, thank you very much. So I just want to finish off by just thanking everyone for joining us this evening. I hope you found it informative and useful, and there will be a recording of this webinar that will be posted onto the CUH website and the YouTube channel, that's a tongue tire, by the end of next week. And I hope you all have a lovely evening and enjoy some of the sunshine out there. Thank you.